Okay, so again, we're just gonna go over all that information. So again, just a review of hemodynamics. You're gonna need to know your central venous pressure, 2 to 8. We discussed week 1, how a lower number associated with they call it dry, so hypovolemic, and therefore your intervention is to give IV fluids. We discussed how having a higher number is associated, they call it the wet, so hypervolemic, in which case we need to give diuretics. And because the CVP is that measurement of the pressure returning to the heart from the body, this is essentially all that fluid that your heart has to is working with to reoxygenate and then pump back out into the body. So if it doesn't have enough of that, then there's perfusion is going to be bad. And then likewise, if there's too much, then it's overloading the heart, and that's also bad. So you need to have this in that normal range for optimal cardiac output. The other number that they want you to know is your pulmonary wedge pressure, also known as the left ventricular end diastolic pressure or the pulmonary arterial occlusive pressure, PAOP. This is the pressure returning to the heart from the lungs. So once that heart pumps the blood to the lungs, there's oxygen exchange, and then that blood comes back from the lungs to the heart and creates a pressure in their left ventricle. So essentially, it is your left ventricular preload. How to interpret this number? When this number is high, it means there's a high amount of pressure in your left ventricle. Why could that be? It could be due to a left-sided heart failure. So if the left side of the heart is having trouble pumping, it ends up building pressure on that side of the heart. So that kind of might also go with hypervolemia. So there's again too much pressure on that side of the heart, too much overload. And then conversely, low would be hypovolemia or potentially decrease due to medications that might alter the pressure going on there. Your cardiac output, you should know that a normal one is between 4 to 8 liters per minute. There is technically a formula to figure out the cardiac output. We know, cardiac output is heart rate times stroke volume. Technically, you divide the stroke volume by 1,000 because stroke volume is in ml per minute. So you gotta divide by 1,000 to convert to liters. But that gives you your cardiac output. And there's technically another formula for it, but you definitely don't need to know that. I wouldn't worry too much about it. Um, you guys very lightly went over the pulmonary arterial pressure. You don't exactly need to know it. I think it's worth kind of recognizing when it might be slightly off, but for the most part, this is just going to be the pressure that is essentially in your lungs. So it's the pressure that needs to be overcome for your heart to pump towards the lungs. So effectively, it's the right ventricular afterload. Your afterload's always the pressure that the body needs to overcome in order to actually pump it somewhere. So it's the pressure inside the lungs that your heart has to push against to make its way through. Again, you don't particularly need to know this for this. You should be able to figure it out based on your CVP and whatnot. Yeah. Again, extra information, your pulmonary hypertension that we've learned in previous semesters. That this could be a way to determine it. So if your mean arterial pulmonary pressure is above 25, it could be a sign of that pulmonary hypertension, which could be caused by some of your other conditions, your lung disease, pulmonary embolism, left-sided heart disease, because if you have left-sided heart disease, fluid starts backing up into the lungs, in which case the pressure in the lungs increases. You guys very lightly talked about systolic PAP and diastolic PAP. Don't need to know that. Um, it's probably good to know for the if you're gonna be in the ICU, just because I think a lot of the time, you can use the diastolic pulmonary arterial pressure to kind of get an estimate of this number here, your wedge pressure, without having to wedge the balloon, because your wedge is essentially like a one-time thing, while this PAP is continuous. So people might just go off this number or the mean PAP because it's kind of a guesstimation. But again, extra information, don't worry too much about it. And then this is definitely extra information, but this is just the systemic vascular resistance. This is essentially your afterload that the left side of the heart fights against to actually pump out to the body. And you don't need to know this number. But yeah, so whenever you have these medications that affect your afterload, it's typically going to be um, affecting this right here. So the reason why you're decreasing your afterload helps with your cardiac output is because it makes it easier for your left ventricle to pump out to the body, because that pressure, that systemic pressure in your body is less. So there's less to fight against. Okay. And again, there's a formula for SVR. So you can, if you have your map and your CVP and your cardiac output, you're able to calculate the systemic vascular resistance, but you don't have to know that at all. It's just there. Again, if you were interested in the ICU and it might interest you, then there you go. The stroke volume. Um, this is essentially how much volume your heart is actually pumping out per beat. It's nice that it actually correlates with a normal heart rate, so that's very nice. And something that, again, Barry got very lightly touched on is the mixed SvO2, which is essentially a measurement of your deoxygenated blood. It shows that by measuring it, it shows how much O2 the body is using. And this is your normal value here. But again, I don't think it's too relevant for this class. It's just like a nice little extra information for those that are interested. Okay. And the lower amount of O2 that's in the blood, the worse the cardiac output, because that means that your body is using up more of its reserves, essentially. So if this number is less than the 65 to 75%, the cardiac output is essentially worse. Okay. Any questions on what we just went over? So otherwise, we'll go on to crap, which he also mentioned. Again, this is all review of hemodynamics, and we'll go over the very specifics later. So your crap, that's the things that affect the cardiac output. So this is going to be factors affecting cardiac output. Contractility, so how much the heart is able to actually contract. If it's going to be stronger, then naturally you're going to have a better cardiac output. Um, that contractility can be measured by your echocardiogram to get that ejection fraction. So we know that people with heart failure, they can have really low ejection fractions. So again, just a guideline to go over, nothing to hard memorize here, just kind of a guideline. So less ejection fraction, typically that's going to mean that your heart muscles are weaker, they pump less. Hence why heart failure, pump failure kind of goes together. Rate, so a higher rate, remember your cardiac output is measured by heart rate times stroke volume. So a higher heart rate will equal a higher cardiac output, but this has diminishing returns, because if you're going too fast, you're also not giving the heart enough time to fill up all the way, and therefore you're kind of not pushing anything actually out, because yeah, so it leads to essentially a decreased preload because your heart not allowing your heart to fill up all the way. So even though you're going really fast, you're not pushing much out. So that will end up having a decrease in your cardiac output. So your atrial kick. So people with AFib, they have a really fast atrial rate, but that can end up leading to a decreased cardiac output because of those diminishing returns that I mentioned prior. Then there's the afterload and the preload. So your afterload is the work the heart has to work up against the system. So here, yeah, think how there is less pressure going through a larger needle. So, or you can kind of think about when you have a garden hose. If you were to constrict it, there's more pressure. If you were to um, not constrict it, just let it open up, then it has less pressure going through. And that's kind of the concept of your vasoconstrictors versus your vasodilators and how they help to promote circulation versus preload, which is the stretching of the heart. It's essentially the pressure that's in the heart. Um, and there's the Stirling's law, again, extra info, don't worry about it too much. But essentially, bigger stretch, bigger contraction. But yeah, that's just things that you can think about. Just a mnemonic for you to think about, changes to the cardiac output. And now we're going to move on to some of the actual specific conditions rather than just general concepts. So we're talking about cardiogenic shock. There are other types of shock that we go over, but focus mostly on the cardiogenic shock because this is a hemodynamic quiz, so that's going to be our focus. So for cardiogenic shock, I wrote down a list of causes. So an MI cause cardiogenic shock. And cardiogenic shock is essentially a pump failure. So it makes sense that if you're having heart ischemia, heart death, that your heart might not be able to pump particularly well anymore. Severe heart failure. We talked about before how heart failure is essentially like a pump failure. So if it becomes really severe, your heart is completely overloaded. It's essentially drowning. It's not going to be able to pump anything. That could lead to cardiogenic shock. Certain arrhythmias, if your heart's beating in a particularly strange manner, then it's not giving out effective pumps, in which case it's not getting the circulation out. And then lastly, the cardiac tamponade. So that's another complication of your cardiogenic shock. But your cardiogenic shock is definitely a life-threatening complication that you have to think about with other conditions that we'll talk about in a little bit. But yeah, cardiogenic shock, the life-threatening complication there. So what I will ask you guys here is we're going to talk about so some of the hemodynamic stuff. So talk about CVP, PAWP, heart rate, and anything involving in hemodynamics. What is affected when you have cardiogenic shock?
High pulmonary wedge pressure.
Yeah, so just like Michelle and Josh mentioned, you do have that high wedge pressure, the high you're gonna have high SVR due to clamping. Okay. A low cardiac output. Yeah. Tachy sweating. So these are some signs and symptoms. So I'll include those as well. So we have tachycardia. Um, we have sweating. So diaphoresis. We're gonna have right here high WAP. We said high SVR. So high systemic vascular resistance due to clamping down. So your body compensates. What else? Cold feet, delayed cap refill. Yeah, so these are potential side effects. Anything else for hemodynamics? So any other things that get measured? We said low COP, low cardiac output, or decreased cardiac output rather, to be more specific. Outer level conscious, decrease, yes. So all of these things. So outer level of consciousness, you can have decreased urine output because your body's trying to compensate and it needs to retain as much as it can. So that kind of goes with that. It kind of goes with, let's say, due to impaired kidney perfusion and or compensation through the RAS system. There we go. I was looking for that one. There's one more. So it's not just PAWP, but also the CVP. So because you have pump failure, we talked about above how when it comes to the PAWP, a high PAWP can indicate a left-sided heart failure. So because left side of the heart is having a difficulty pumping, that fluid and that pressure builds up on the left side of the heart. So if the same thing happens on the right side of the heart, you have right-sided heart failure, then you're going to have the same thing where fluid is building up on the right side of the heart. And that pressure on the right side of the heart is measured by the CVP. So you will have high CVP and high PAWP due to pump failure. It starts to build up in the heart. And we've mentioned, so we'll go with high heart rate as well due to compensation, high SVR, your body starts to clamp down. So because you're not able to pump, even though you're essentially overloaded, the heart's not able to do anything with that. It's drowning. It's not able to actually do anything. Your body will try its best to pump as much as it can, but it can't compensate well enough. It'll try to clamp down, so the vessels will try to clamp down. Yeah, so you will have decreased blood pressure over time. So over time, that blood pressure is going to dip. So over time, low BP due to the low cardiac output. Yes. So this is again, like we talked about, we have that overload. So we are going to have pulmonary edema. We're going to have generally edema, but especially the pulmonary edema. We're going to have an ability to get rid of to circulate out the fluid. It just starts building up, unable to actually utilize it. So good. So we did that. We did that. So the goals of therapy would include what? Yeah, of course, we're gonna try to improve the cardiac output. We're gonna try to, sure, relieve some pain. And yeah, we're gonna think a lot about crap. We're gonna think about the afterload, the preload. All right. So what are some diagnostics then that can be used to kind of assess this condition better, assess this condition, determine what's going on? Yeah, EKG, echocardiogram. So we talked about how it can echocardiogram. I talked about how ejection fraction is a big deal when it comes to how the heart is working mechanically. The EKG can show us if there's muscle damage, electrical issues. So that muscle damage in the heart would be, how would it manifest on an EKG potentially? Chest X-ray for pulmonary edema, cardiac enzymes. Yeah, so blood tests for cardiac enzymes. ABGs. So we can go into acidosis from lack of proper oxygenation. Echo, yes. Echocardiogram, EKG. So echocardiogram to assess for ejection fraction, EKG. Yeah, how would muscle damage show up on an EKG? Yeah, ST elevation. We can check to see if there's ST changes that can occur from an MI, that can occur from even like unstable angina might cause ST elevation, which is why we need to do assess for ST elevation and do the blood test, do the car and stuff. And then some people might have chronic ST elevation due to past MI or heart damage, so things to keep in mind. think about isolation. Yeah. ST depression could be, yeah, it's either for ischemia, could be uh, the ST segment being normal or even slightly depressed. And then in terms of treatment, so you've already kind of shown me some. So let's see. It's going to be a lot of these inotropic medication. So inotropic. So that includes medications that are positive inotropic. So medications that are good for increasing cardiac output, the three Ps for um yeah, a lot of heart failure medications, yeah. So let me see, anything else that we're talking about? Mention that. What other management could be done for this person as I continue? So let's look at some of the signs and symptoms. What do you think could be good for someone that has tachycardia, diaphoresis, pulmonary edema? Let's add this as well. Shortness of breath, altered level of consciousness. If you see someone having all of this, what's something you might want to consider? True. What about just kind of like looking at him? This guy's got shortness of breath, pulmonary
Oxygen.
edema. Yeah, let's try maybe some oxygen as well. They could be oxygen supplementation. They might need a ventilator. They might be good on a mask. We mentioned how um yeah, the for the most part with this condition, do you want to give fluids or how are we fixing the hypovolemia? Are they hypovolemic?
No, they're not.
So they're not hypovolemic, but they are hypotensive. The fluid's just not in the right place. So for the most part, you are worried more about these inotropic medications. But it's all, again, very, very dependent on what your Swan scans catheter says about your CVP and your PAWP. Um, Depending on how those values are, can change the treatment. So someone um, with this condition might even be, I think, eligible for like some diuretics, even though they're hypotensive, because the reason they're hypotensive is not because they don't have enough fluid, it's because the heart's not pumping well. So by using some diuretics, the patient can it stops like overloading the heart, so the heart's actually able to pump what it has. Essentially, if it's overloaded, then it has too much to work with and it's not able to do its job. So it's kind of like where like where knowing like the exact action and mechanism of your medications can come in handy. We don't like usually you can simplify diuretics, so diuretics will lower blood pressure. But in this situation, lowering the getting rid of some of that fluid might actually help the blood pressure because we're also assisting the heart in actually being able to pump appropriately, if that makes sense. So again, it's all up to what your CVP, your PAWP values are, but it's just stuff that's worth thinking about. And then let me know if any of that was confusing. So we have the butamine, we can have dopamine, milrinone, and let me see if I can. What are some specifics with the butamine? So we're gonna give this. It's a positive inotropic medication, so this is going to improve your contractility and cardiac output. Anything else? It can cause hypotension. Is it? Is there anything else that it can do? Where does that hypotension come from? Does it lower your blood pressure? Uh-huh. Yes. So this is going to improve contractility and cardiac output, but it can also cause an increase. increase in heart rate, which can lead to reflex hypotension. So from that increase in heart rate, your body essentially has to compensate for the tachycardia by decreasing the blood pressure. So it's worth noting that I don't know if this is something he mentioned, just like systolic blood pressure should probably be at least 80 plus before giving. Dopamine, what does dopamine affect? Yeah, so it will cause an increase in heart rate and blood pressure. So we're just getting some information from your medications here. What about Milrinone? What else is Milrinone doing?
Increases your heart rate.
Increases your heart rate. Does it affect anything else?
Can it cause dysrhythmias?
That is not something I'm too familiar with in terms of that, but look it up for you. Let's see. If it hasn't, it might have an effect on your QT segment. Let me see.
I think it, I think what I have is that it can affect, we have to monitor potassium and magnesium really closely on milrinone.
Okay, let me see. Let me see what we got.
Maybe.
Yeah, I'm looking at it. Looks like it has an effect on enhancing calcium availability in cardiac cells, which I can imagine could potentially lead to some dysrhythmias. So increased risk of ventricular arrhythmias like PVCs, VTAC, and BFib. So yeah,
Wait,
nothing.
sorry, I
Yeah,
stepped away, but yeah, you do have to monitor the potassium and magnesium.
cool. Good to know. So let's think about that. So monitor electrolytes. So let's say potassium, calcium, magnesium. All right. Anything else?
Can it also decrease the blood pressure?
Yeah, it can cause a decrease. It can also cause vasodilation. So it can cause a decrease in BP and systemic vascular resistance, which in this scenario can be potentially a good thing. Me too, dysrhythmias. I'm trying to find the correlation between them. I spelled this, I'm really wrong. What's the exact mechanism? So let's see, let's see. It can increase intracellular potassium shift and renal potassium excretion. So it can lead to, yeah, it can lead to increased loss of potassium in urine. Okay. And essentially increase the amount of potassium that's transported into the cell. So yeah, so definitely your potassium for sure. Cool. Okay, any other potential interventions for this person here? So we talked about that. We talked about potentially some diuretics. Digoxin, yeah. So uh for this one though, let's see. I know he doesn't specifically mention it, but it should still be theoretically fine. Uh. So I'm seeing here, digoxin is not ideal for cardiogenic shock because of a slow onset of action, which is, I guess, why he didn't list it, even though it is one of the, I hope he used this with you guys. He said like pump that D. I think that's hilarious. Did he not? Okay, that's funny. That's how I remember it. It's like the butamine, dopamine, digoxin, pump that D. I'm like, okay, nice. I'll never forget that. Yeah, anticoags, antiplatelets. So recall that one of your potential causes is your MI. So yeah, person can be on blood thinners. Cardiogenic shock while treatment could lead to arrhythmias, and those arrhythmias can then lead to if like different clotting stuff. So blood thinners. So we have aspirin, which is an antiplatelet. He mentions like what? Integralin, which is an antiplatelet. I wouldn't worry too hard about that. I've barely heard of that. Heparin drip, anticoagulant. And he mentioned alteplase, which is a thrombolytic. And then something else that I'll add on is your IABP. So your intra-aortic balloon pump is when all else fails. When nothing else is working, the IABP is an intervention. Or including even like some ventricular assist devices as well. A cabbage. Probably like once we stabilize the person. Okay. A lot of good things. A lot of great things today. Any questions on anything so far?
Yeah, I have a question. Are we gonna use pressors if they are hypotensive in this situation?
So let's see. In this
Like,
situation, yeah, I got what you're saying. I think I believe in this situation, let me double check this, but I know like for sure our inotropic medications um are going to be like your one of the main things you do. And I have seen some questions, not talking about the test, just from like studying, like doing things on Quizlet or whatever, where they were actually using like nitroprusside for cardiogenic shock because based on like the PAWP, they were doing things with that. Um, so let me look it up to be exact because it's not like I've had a cardiogenic shock patient. I imagine it should be fine. Okay. So it says here, yeah, they can be used with the inotropes, but it's worth being careful because it might also increase the oxygen demand, the myocardial oxygen demand. So like a lot of the medications that get used, like norepinephrine, is going to affect sympathetic nervous system. So essentially fight or flight. So your body's going to need more resources, which could be detrimental if you have heart ischemia. Your heart's not getting enough proper oxygenation perfusion. So kind of like if you remember your MONA, your morphine is one of your interventions for an MI because the morphine is a CNS depressant. So it decreases the oxygen demand. It sedates your body to the point where you need um, less oxygen to function. Kind of like when you're sleeping, your respiratory rate drops and your heart rate drops because you need less resources because you're sedated, you're asleep. So it's kind of like the opposite idea where you're in a fight or flight, so you need more resources, which might be bad if the patient's particularly having issues with heart ischemia. Hopefully that answers. I don't even know if that answered the question. Says, so let me see the play. If you want to keep the leg straight. Yeah, so we're going to talk about that in a little bit. We have to be careful. Okay, so if no more questions, we'll move on to the IABP. So IABP is a mechanical device used to support the heart's pumping function when you have heart failure. So it will assist you with your pumping, which is great. Because in this scenario, for example, if we have pump failure, it makes sense that the the thing that helps you with your pumping is utilized, so that's why it's an option, but it's also very invasive, so hence why you would rather do the other stuff first. I'll add ventricular devices as well. What is the goal of the IABP? Yeah, so essentially, yeah, all right answers. So yeah, we're gonna try our best to increase that cardiac output, improve coronary and cerebral perfusion. So that's gonna be our goal, is to increase cardiac output and improve coronary and cerebral perfusion, because two of the most important organs in our bodies are the heart and the brain. So that is the goal, because if you have pump failure, then that's kind of not happening. So we're gonna help the heart here. So some indications, we talked about cardiogenic shock a lot, so that's gonna be one potential. Anything else you guys can think of? You have to be pretty severe heart failure, like essentially heart failure can lead to cardiogenic shock. So it would have to probably be like a heart failure that's bad enough that you get shock and then get this done. I'll just kind of write some of these stuff down. So it's like a bridge for the cabbage. So kind of like in between state for cabbage is done, they might do this to kind of get something going. So if this person, for example, might be having an MI, they might be having severe heart failure. They go into cardiogenic shock. We give them oxygen, we give them the medications. We try our best to kind of work with the Swan-Ganz and try to monitor their pressures. But none of it's working. They need to be placed on an IABP to try to assist them, and then we're going to do a cabbage to try to, once we stabilize them, to essentially try to find a way that they're no longer going to be in shock. Their heart's actually able to pump. We kind of divert that freeway and allow for circulation to properly occur, not overload the heart. They're probably like the two main ones. And I think some of us were already talking about assessments for the IABP. So we talked about positioning. So for the most part, this is going to be done on the femoral artery. So positioning. So you're going to want to keep that leg straight. So positioning. This is done on the femoral artery. Therefore, we're going to want to keep that leg straight. I'm going to say head of the bed, less than 30 degrees. Less than or equal to the U world. I remember very specifically said less than 30, so I will go with less than 30. Want skin care because of the high risk of infection on the femoral artery, especially with patients like incontinent or something. So it's worth to kind of think about that. Yeah. So this is where you're going to monitor your distal pulses. That's your pedal pulses. You're going to monitor what else? So if this person has this thing going on, what else are you going to monitor? Let's just think about just based on that site. And then, okay, yeah, and these are also very good. So all your perfusion assessments. Because what could happen? Yeah, we're going to assess the distal pulses. We're going to do, I just said like a good perfusion baseline, yeah. Yeah, so that's kind of always your goal, is get that good baseline. So what's their level of consciousness? What's their cap refills like? I like that. Their eyes and nose. You like that? Yeah. So Yeah, so clamping blood flow to the kidney. Yeah, so that's one of the key things with this is you're gonna want to really think about your complications with your kidneys because what can happen? What about the IABP could lead to kidney issues? And then what are some other complications? That could be something that affects it. Say that again, please.
AKI. Acute kidney injury.
Acute kidney injury, and what would be the reason that occurs? I'll try to get a good picture of this as well.
Because the balloon pump can occlude the renal artery, so it'll
Yeah.
cause decreased urine output.
Yeah, so your balloon pump is able to potentially occlude that renal artery. So let me see if I can get a good picture of that. Thought I had one prepped, but I guess I don't. Like one that actually points out the renal artery. That should work. Okay. So with the kidneys, so yes, the IABP is able to potentially occlude it, so that's going to be something to think about for sure. And let me get the chart open again. Yeah, if we're talking about contrast, then yeah, the mucomist can be good. But in this scenario, we're specifically for the IABP, the balloon can be placed too low and obstruct renal perfusion. So that's why the eyes and nose are very important, your labs, but more or less your eyes and nose. So the patients will have a Foley catheter. And will need to be monitored for eyes and nose. Specifically, their urine output should be at least that 0.5 to 1 ml per kilogram per hour. That is very true. What else could happen from the constant inflation or deflation? Oop. Yeah, so they can have fully. So if you were having a vessel that is consistently having a balloon inflate, inflate, deflate, inflate, deflate.
Your blood cells can rupture, causing thrombocytopenia.
True. So we can have, again, thrombocytopenia, but yes. So like Josh mentions, the rupture of the aorta is possible because essentially you're harassing it so much, it can cause weakening of the vessel and that could cause a rupture. So that's another big complication that you are probably going to get tested on. As long as you're able to identify the honestly pretty obvious signs of it. So what are those signs for it? So let's test for Turners. I do like that. Yeah, so that flank pain. Usually I think I see questions describe it as like a tearing pain. A tearing flank back pain. Or even abdominal pain. Depending on the area. Yeah, with no relief. Very hypotensive. Hypotensive very quickly. Patient needs surgery. So this is an emergency. That's something that you got to think about. We talked about thrombocytopenia. Section due to weakening vessels. So then let me see if I can get a good picture of this pump right here. Here you can see this is the IABP, this is the renal artery. So that's why I like this picture because it actually shows the renal artery. If this was misplaced, this balloon could be a little bit lower, and now you're blocking the renal arteries and the kidneys hate not having perfusion. So, yeah, kind of, yeah. This is a little bit higher than the AAA, I believe. This is, I think, be more of like a thoracic. But essentially the same idea. There are a lot of the same signs and symptoms for the rupture. The aortic dissections are pretty much the same in that case. Let's see anything else. We talked about the perfusion, position of the skin, the kidneys. You definitely don't need to know exactly how the balloon pumping helps. Just know that it helps, and that's all you need to know. So don't focus on that. All right. Any questions on IABP? This is going to be key. Your kidney in general is key. Definitely need to know this. Of course, you got to do that perfusion baseline, get the pedal pulses on the affected limb. All right, we're good. All right. So now let's talk about valve replacements. Some general information I have, the different kinds of valve replacements. There's a mechanical valve, biological valve. The mechanical valve, you can actually hear the clicking sound, and I've actually heard a clicking sound on the patient before. I think I've told the story to you guys before. On the floor, I heard a clicking sound. I thought it was weird. It wasn't documented anywhere. The nurse didn't know anything about it. She also didn't listen after, but I went to my teacher. We both went to the patient together. She heard it and she said, "Ask the person, have you ever had a valve replacement?" And that's exactly what happened. She had a mechanical valve replaced. Yeah, they're on anticoagulants for life. So patient will likely be on, and I put this in magic color. Coumadin or Eliquis for life. Eliquis more likely nowadays. But especially so if they have a mechanical valve. I believe with some of the synthetic valves, they might not need it, maybe for a short period. But for the mechanical valves, they do need it for life. TPMA, toilet paper my ass. I remember that. I forgot what that was what was that for? Just remember him saying it for the valves. Toilet paper my eh. But yeah, so that's pretty much all you have to know about that. But what are your nursing considerations with your valves? And very specifically, he wants you guys to know the teaching. And this comes up a lot on UWorld, by the way, in terms of the specific, some of the specific nurse considerations. Yeah, there's chest tube. So this person's going to be on a chest tube. They're going to be in a 1:1 ratio in the ICU. This person's going to need some education on if they're on Coumadin, they're going to need to know about their vitamin K. Is that specific to valves? It's going to be specific to valve replacement or as well as anything that causes damage to the valve. So much regurgitation, people with valve regurgitation, people that have damage to the valves, maybe due to an endocarditis, for example. But then need to have their valve replaced because they have like weakened valves. Anything where there's an issue with the valves can lead to vegetation growth, getting stuck in that area, in which case that becomes the infective endocarditis. So people with valves need to be replaced, regurgitation, or people who've previously had endocarditis and had damage to their valves. But yeah, the concept would be that you need the antibiotics before dentist because we have that that area can have circulation, can lead to having bacteria reach the circulation and then get stuck in the valves and lead to vegetation in that area. So we said Vitamin K, consistency when on Coumadin. We said monitor the chest tube. So what are you monitoring for in particular? What are some things about chest tube that you want to keep in mind? And what else did we mention? Essentially, if the output suddenly stops, that's potentially occlusion and potentially a clot. The first few hours, you'll see a lot of drainage. How about when it starts to stabilize? When do we want to call the doctor? Yeah. Any other number that could be okay to call the doctor if we're monitoring? And this might be like a 220 chest tube question. Oh, is it a Niggy? I think,
Pocket icky says to report anything over 150.
okay. We'll go with that then. I think in 220 they said anything more than 70. But if your most recent pocket Iggy says 150, we'll go with that.
Wait, that's post cabbage. Don't listen to me. Sorry, that was my
I mean, post cabbage, you will be on a chest tube either way, but I mean, I'm going off general, so this is like a general more than 70. But again, I'm sure it completely depends on your policy and your own brain, like your own decision making. Yeah. Oh, I would say, huh?
But what you say?
Well, I'm just gonna say the test is the same. Uh, and I learned it as a more than 70 and I was fine, so we'll go with that.
Yeah, it says drainage greater than 70 milliliters per hour
All right, we'll go with
in
that.
Iggy, in the big Iggy.
Oh, Big Iggy different from Little Iggy.
Yeah.
Interesting. That's weird, but this is the old curriculum and they're going off very old stuff, so we'll go with uh
Old.
the old yeah. I found out today that Miss Hively, so Miss Hively graduated from Cerritos College, right? I found out today that her curriculum is the same curriculum we had. It's the same curriculum. I'm sure they've made minor updates, but the general baseline is the same. So
When did Miss Hively graduate?
that I don't know, but I think
Oh,
she's been working
shoot.
for a bit.
Yeah.
Yeah. I'm sure if I really wanted to, we could like look her up on like Google because everything's public for that. But yeah, it's research for your own time, I guess. Right. So it would be like once it stabilizes. So the first couple hours, we're getting a whole bunch of stuff down. And then once we kind of start having it starts to decrease. And let's say they've been, again, a part of it is also going to be like changes. So let's say they stabilize down and it goes down to like 40 ml per hour. Then maybe like a few hours later, it goes up to 50. It did go up, but it's like it's still not too bad. But then if it keeps going up and it crosses that threshold, then that's when we need to start doing something about it. Essentially, that's essentially the idea. So first couple of hours, this is gonna go crazy. Once it's stabilized, if it reaches this threshold, it's worth looking into. And even and I would say even before the 70, if you hit, if you're noticing a trend, that's worth keeping in mind. These guys want to put in their own room if possible and not place someone with infection. Yeah, for sure. So what else did we say? That. Antibiotics. Before going to the dentist to prevent infective endocarditis. All right. Anything else to monitor with these people? So they're on a chest tube. So what are they losing? What do you want to assess? I'm sure we said it before, but I'm just gonna scroll it. Yeah, so they could potentially, yeah, so definitely the O2 is good. So patient education, let's say potentially O2 supplementation when appropriate. I'll just add in this and I'm sure if you saw this, you would see it, you would know. Vital signs every 15 minutes. In the ICU, they do vital signs super often. The amount of assessments is very often also, like full assessments is pretty often as well. We mentioned that need to be placed on their own room, so that would be like a not like a patient education thing. Patients should be in their own room to prevent infection, prevent DVT, assess for bubbling. Yeah, so like with the chest tube, assess for, um, let's say consistent and high bubbling or persistent bubbling in the which part of the chest tube is it? This comes up on the eWorld a few times actually. In the water seal, yeah. And just keep in mind that specifically it's like constant bubbling. Intermittent bubbling is fine. Especially when you're first starting. Yeah. And we said monitor for chest tube, monitor for AKI, so kidney function. It's a ventilator stiff. So ventilator BAP bundle. That came up in your test. That came up for you guys, huh? The in the test you had, I guess it was last week. Yeah. All right, cool. All right, so we all got it right. We all got there. We all survived. Okay, that's pretty much it. Oh yeah, I think someone mentioned this too, hypothermia. So for this one, they can do the bear huggers. And what else? Monitor for AKI, pneumonia. It says for FBO or FBD, fluid volume deficit, fluid volume overload. So they're PAC readings, Swan-Ganz readings. Utilize them. So CBP, PAWP, et cetera, et cetera. Okay. I think that's good. And speaking of issues with the valve, we'll move on to infective endocarditis or general information is going to be infection caused by bacteria. Don't worry about the origin of cause. This is just background. So we have vegetation, so essential growth inside on the valves. But because the valves are in constant use, constantly being used, it's difficult to kind of get rid of it. So you need the specific treatment that is done for this. But yeah, it can include infection, heart valves, endocardium, septum. But in general, the main thing you need to know with your endocarditis is what can it lead to?
Valvular disorders.
Yeah. So heart failure / cardiogenic shock can lead to Guess I won't say it just because it's more common with the other one. But yeah, cardiogenic shock / heart failure. Yeah, so it can lead to heart failure, which can then progress to cardiogenic shock. It can lead to like an abscess, like a myocardial abscess. So like again, the abscess in the heart. Left untreated, it can be fatal. And so some risk factors. We talked pretty extensively about this, or we talked pretty extensively about the valve replacement recipients. We'll just mention a few others so we can kind of move on. So anything where, again, you have problems with the valves getting things across, so those bacteria can build up and become vegetations and growths in the valves or whatever other area of the heart. Okay. So what about your diagnostics? What are we doing for this? Ultrasound, echocardiogram. What's your definitive diagnosis for? And yeah, blood culture. So this is your definitive. And now let's see some. You can get TE as well. That specifically echocardiogram. You'll probably see a transesophageal ETE. I had a patient that I didn't really get to know how it ended, but we had a patient that suspected for infective infective endocarditis, and they were gonna do a TEE, and this was during the preceptorship. Very interesting. Yeah, what are some signs and symptoms? Fever, chills, yeah. So just flu-like symptoms. What was the last time you guys ever had a flu? Because I haven't had a flu in since I was like 9. Oh wow, really? Murmurs, yes. So hard murmurs. Yeah, it's been a hot second. So hard murmurs, heart failure, like signs and symptoms. So we're talking about peripheral and pulmonary edema. Oh wow. Yeah, people die of the flu. That's true. It sucks. That's why getting the flu shot can help a lot. Oh, we talked about the Janeway lesions, oscillatory nodes. I would say, and the hemorrhaging, fingernail splinter hemorrhage. Yeah, there's some specifics about all these that you don't really need to focus too hard on. Yeah, so for example, Janeway lesions are non-tender, red nodules. Osler nodes are painful, tender. And one of them is clot related, one of them is like an immunity thing. Is a late sign, but again, don't focus too hard on that. I do have a picture for it, but don't stress too much about these two. Probably here is good. And picture for the splinter hemorrhage. You'll probably see this come back up again for once you guys start working on UWorld and Kaplan and studying. I think I had a few, not on the NCLEX. The NCLEX was never got to anything super detailed, but the UWorld had some infective endocarditis stuff. But yeah, the NCLEX is pretty simple. Nothing too crazy. I think we already talked about petechiae. There's also pain when breathing. And these are going to be your main symptoms. So what is flu-like symptoms? Fever, chills, fatigue, shortness of breath, aching joints. But I think one of your distinguishing things with this is that you do have heart murmurs, and that's kind of an expected finding with this one. Anything else here? We talked about that. We talked about the signs and symptoms. What about the management and some education that can be done for all of this? So how do we treat an infective endocarditis? Cool, cool, cool. Yep. Where's my writing? There it is. Antibiotic. This is going to be the main treatment if it's caught early enough. If it's the patient might have to go home on a PICC line, yeah. What else we said? It said HH, home health, IBA, antibiotics, hold Lexersol and column D, take antibiotics before dentist. Pretty much, yeah. So antibiotics. Likely to go home on a PICC line with antibiotics. All right, we're gonna treat the heart failure symptoms, and I know you guys know this pretty well, but you are gonna have to know your diuretics, your ACE inhibitors. So if you are a little iffy, your beta blockers, calcium channel blockers, digoxin, dilators. So just review so you have the general idea. Person might need to do like a valve surgery. And some patient education you guys mentioned, and we did talk about this a lot. Is that any antibiotics for 6 weeks or more? Be on the PICC line, I guess. Antibiotics before dentist, and call MD if we'll go with fluid overload. And what's the yes, exactly. Yep. So more than 2 pounds in a day, more than 5 pounds in a week. Okay. Fever, anything more than 1.4 Fahrenheit. And I believe that's what, more than pretty much 38 plus Celsius. Chest pain, shortness of breath, severe abdominal or flank pain. So we might have some kidney impairment happening. And of course, if you have splinter, if you have, in general, it's like call them if you have a sign and symptom of heart failure, infection, bleeding. That's your TLDR. And then lastly, I'll ask you guys, is this person infectious to others with their infective endocarditis? Yeah, so we're gonna do standard precautions on this person. Cool. So that's kind of it. Any questions on infective endocarditis? What do we have left? We have pericarditis, cardiac tamponade, AAA, coronary cabbage. I think these will be a little bit faster, but we'll see what we can do here. It's only been an hour, I guess. It's okay. All right. So pericarditis, general information, it's an inflammation of your pericardial sac. If someone has had pericarditis, they have a higher chance of having multiple episodes. They've already kind of caused an insult to that layer, so it can become a recurring thing. Again, this is just extra info. It can be viral, bacterial, fungal. It's usually viral, but it can also come due to trauma. So the insult to the pericardium, which is you can have the odds of having more episodes. Again, this is just extra stuff here, if you were curious. So what diagnostics are done to determine if someone has pericarditis? Yeah, so let's see the chest x-ray. We'll be able to see what's going on with that pericardium. MRI or CT scan. Echocardiogram, because we're looking at the heart, so it makes sense. EKG to see if there's any changes, any labs. So we're looking at. Yeah, so let's see if troponin, so your pericarditis can lead to, yeah, all these insults. So they can have troponin, their blood cultures, of course, and as well as some inflammatory markers. So that would be your CRP, your ESR. Yeah. So cool. When it comes to your pericarditis, what can it lead? Is there anything that it can lead to? Yeah, it can lead to tamponade. It's kind of like I guess you could say it could be like a little bit of a like almost like a progression. You can go pericarditis leading to cardiogenic shock, and then the cardiogenic shock leads to tamponade. But that's kind of how that generally goes. But one of your key things with your pericarditis questions is going to be knowing, being able to determine when it's going into tamponade, and we have a way to do that through the it's called the Beck's triad. So that's really what's going to be your management. So what is the Beck's triad? Let's talk about that. What are we assessing for that? Okay, yeah, it's going to have the hypotension, JBD, yeah. Yeah, muffled heart sounds. These are your three things here. There's some other stuff that kind of go with it, but these are traditionally this is the three that kind of go with your Beck's triads. Hypotension, kind of accompanied with a weak pulse. JBD, which we know is because of fluid overload. Muffled heart sounds because there's fluid around the heart. Yeah, tachycardia. So weak thready, tachy pulse, muffled heart sounds, fluid around the heart. All right. Clamping down to level of consciousness. Yeah, so if we're going off signs and symptoms, alter level of consciousness, we have tachycardia, the shortness of breath, and we talked about, let's actually go here, sorry. Well, this isn't necessarily like, this is like cardiac tamponade. But yeah, that's kind of one of the things you're assessing. Let me comes with a lot of, actually, I think we're talking about, let me kind of back up. So we are here for, because that's what we're assessing. So we assess for Beck's triad, which is becoming cardiac tamponade. And then let's go back to here. The defining feature of pericarditis. And this comes up again. This is something that also that comes up in the U world a lot. Is the chest pain. There's something in particular about this chest pain. So let's just describe. It can be sharp and stabbing, felt in the neck, shoulder, back, or abdomen. Yeah, so one of the key things, and this is something that comes up in the U world a few times, is going to be the fact that it's relieved by sitting up and leaning forward. And that's due to the positioning, which essentially allows for that pressure built up by the fluid in the sac to not be pushing on the heart as much. So relieving with sitting up and leaning forward. And that's a key thing with that one. When you listen to the heart, what's it going to sound like? Sorry, we'll listen to the heart and lungs. What's it going to sound like? Yeah, you're going to have a friction rub. So you're going to have those sounds. And if you really want to hear that friction rub, you can tell them to, you can put your stethoscope in that area, tell them to hold their breath so that the breathing doesn't get in the way of your, of listening, because the friction rub will happen whether they breathe or not. It's happening due to the inflamed pericardium rubbing against them. And then with that friction rub, you do have also muffled or distant hard sounds. Anything else? What about the lungs? Yeah, this person could probably have some shortness of breath. Probably have something else as well. So we have kind of similar to the other one. There is a degree of overload happening here. So pulmonary effusion, so yeah, crackles in lungs, and or decreased lung sounds. And again, this is the types of condition where even though these people are essentially overloaded, they can become hypotensive because of that pressure or that overload on the heart, making it so that they can't pump. So they go into a essentially that compression of the heart, making it so that you're not able to pump effectively. Okay. So we talked about assessing. So that's something we can do to kind of determine if it's becoming cardiac tamponade, but then how do we actually manage pericarditis itself? So we're going to look back at some of the causes. So it's primarily yeah, so again, we're going to go with O2. Positioning, we talked about the positioning that is effective. Sit up and lean forward. With a pillow, potentially. Pericardiocentesis. So yeah, pericardiocentesis. So if we have a bunch of fluid built up in the pericardium, then let's drain some of that. The pericardial window, yeah, that could be a way to allow some of that infected fluid to drain. So this is cutting hole into pericardium, allow infected fluid. Boom. Thoracotomy, that kind of goes with the pericardial window. That's essentially what it is. It's a pericardiotomy, which is essentially in that area of place. So fluids to pump it forward. So right now we're thinking of cardiac tamponade. So with the fluids and stuff. This is just, we're talking about pericarditis right now. So we're just thinking about pericarditis. So in this moment, this person has an infection and has overload and has inflammation of the pericardial sac. And it's that inflammation that's causing some stuff. So what could be effective?
Anti-inflammatories.
Anti-inflammatories. So what could that include?
Corticosteroids.
Yeah.
NSAIDs.
Glucocorticosteroids, NSAIDs, and yeah, steroids. He gave another med called colchicine. I think this comes up in the U world, but other than that, don't worry too hard on it. But colchicine, just be able to recognize it just in case it shows up. Yeah, it definitely shows up on U world. He did that, like mentioned it offhand. He just said it can decrease pain swelling. And with your glucocorticoids, you guys know hyperglycemia, immunocompromise. So we're gonna go with antibiotics, antifungals, depending on condition. So if it's bacterial, antibiotics. If it's due to fungal, then we're gonna do antifungals. And but the weird thing is that the viral one is typically not treated with antivirals just because it's kind of like your meningitis. The viral is self-limiting, so it doesn't really need it. You just kind of you just kind of treat the symptoms instead. Okay. So I would say the main thing with this one, of course, definitely know your general stuff here, but a lot of this you'll see is very repetitive, right? A lot of this stuff is saying the same stuff. We've looking at a lot of similar labs. There's some standouts, but then there's also some things that are unique about this one. I definitely think you guys should know the unique stuff, and then definitely know the assessment here, and then probably some of this here because some of the unique stuff with this thing is the pericardiocentesis, anti-inflammatory meds, the fact that you are assessing for Bactria, but try not to get confused between pericarditis and cardiac tamponade. So even though you're assessing for cardiac tamponade with the pericarditis, don't just always assume that they're like one and the same. It's not always the case. Any questions? Okay, we just have cardiac tamponade, AAA, coronary angiogram, cabbage, and then we can very quickly go over some of the meds. Okay. So cardiac tamponade, we've been talking about it. Compression of the heart due to fluid accumulation. And then all that buildup around the heart prevents the ventricles from expanding fully. If you're not able to pump, organ failure, shock, death. Essentially, that pericarditis gets worse, that inflammation gets worse, the amount of compression gets worse, and you have cardiac tamponade. And there's some key things about this one that in terms of the management that we'll talk about. Other causes here are listed. So aortic aneurysm, so that internalized bleeding then leads to the compression. Lupus, radiation, again, just for your information kind of thing. We'll kind of skip past the diagnosis because you've been saying the same thing over and over again. Chest x-ray, echocardiogram, So your echocardiogram is gonna be the best way to diagnose. Your chest X-ray can show a globe-shaped heart. Let's take a look at that. Look at that. It literally looks like it's inside of a bag full of fluid, which is essentially what's happening. And all of that pressure is preventing the heart from doing its job. Cardiac tamponade is essentially a cardiogenic shock of some kind. So let's add this here. Okay. So in terms of your hemodynamics, what do we see with the cardiac tamponade in terms of some of your Swan-Ganz values? Right. So yeah, you're gonna have a decreased cardiac output, but yeah, you're gonna have an increased PAWP. So think about kind of how when we were all the way back up here with your okay. I guess it'd be with your cardiogenic shock, wherever we were. Surely it was over here somewhere. Actually, maybe even better just to go here. So we see here that if you have pump failure, you have fluids buildup. If you have fluids buildup, then those fluids create pressure in those parts of the heart. So if you're having this fluid buildup that's preventing the heart from being able to pump effectively, then you start having backing up of circulation in the heart, in which case this CVP value is gonna go up because you're gonna be overloaded, you're gonna be unable to pump effectively on the right side of the heart, but you're also going to be unable to pump effectively on the left side of the heart. So you end up having an increase of both the CVP and the PAWP. Just similar to the cardiogenic shock. It's going to be the same rationale, pump failure. Okay. So let's see, what do we say? We said, so let's go Swan-Ganz. Yes, the pressure built up in so your PAWP is the pressure. So it's that pressure that's it's the preload on the left side of the heart. So it's pressure buildup, and that pressure buildup is due to the fluid accumulation on that side of the heart. So it's not like your PAWP is not like how well that left side of the heart is working. It's just talking about the pressure, which is very nuanced because um that pressure could be high because it's pumping, like potentially because it's pumping super well, or it could be high because it's um what's the word? Because of how much accumulation there is. So it's nuanced. It's not black or white, which is why the ICU is critical. Like one of the many reasons why like the ICU is a lot of critical thinking, and why the people there get paid to look at two patients, sometimes only one patient, because there's titration and a bunch of thinking. You're basically micromanaging a bunch of stuff. All right. So we already talked about the Beck's triad, so I'll just copy paste. Boop, boop, boom. Okay. And some things that kind of come with it, chest pain, basically a lot of your typical symptoms when you think about symptomatic impaired perfusion. So a lot of the same stuff. So that's why sometimes a lot of times actually it can be good to start with the big picture and then work to the heavy details, because the big picture, once you got the big picture down, you could just be like, oh, heart stuff. I don't know. I just in my brain's like heart stuff. It's heart stuff. So it just becomes ingrained in your head that way. And let's talk about the management with this one. So we talked about how this one is an ability to pump well. You have high CVP, high PAWP. What is the management for for cardiac tamponade? So we see that this one, yeah, pericardial window. So this condition as well with the pericarditis, they're very close with each other. So you have a lot of the same treatment there. You have the pericardiocentesis, pericardial window, thoracotomy, get rid of that pressure off the heart. But in terms of this condition, yeah, ABCs are the priority. What about fluids? How do you feel about fluids? Giving fluids? Do we give fluids? Do we take away fluids? Okay, Kevin says diuretics. What do you got? What does everyone else think? Do you guys agree with diuretics? What does everyone else think? What's the rationale?
Is it because the fluid is not in the vascular space? So, and they are already hypotensive.
Uh-huh.
So it would kind of worsen that.
So, what else? Yeah, to treat shock. So in this one, this is a condition, and remember when we go back here, I mentioned that there was an exception to, I guess, the quote unquote rule. When we're looking at our CVP here, when this number is high, we typically think of giving diuretics. This is one of the few conditions where even though their CVP and their PAWP are high, we're gonna want to give fluids, because this person essentially, they need to have some degree of preload, and we cannot afford to take that away from them. So we need to um, manage this condition by giving them the preload. Right now, like they have a bunch of pressure on the heart, which makes it harder for them to pump forward. But by giving them fluids, we're able to increase the preload, so that more of it actually makes it through. Um, I think this is something that I think in 232 you might have very slightly gone over it. it was the idea of a right-sided MI. So a patient with an MI that's specifically in the right side of the heart. Normally we think about like MI, we think about Mona, we think about morphine, oxygen, aspirin, and nitroglycerin. But for someone with a right-sided MI, that nitroglycerin is actually contraindicated because their right side of their body is already struggling, and that nitroglycerin can decrease the amount of preload they're able to get. Yeah, exactly. They need the preload. So it's the same idea here, where again, also the fluid is usually primarily like in the sac. It's kind of like like one condition, like we talked about how pericarditis kind of can become cardiac tamponade, and then in here, um, I guess it doesn't really mention whether you use diuretics or not for this one, but the main concept is just that you want to give them the preload. They need something to work with in this condition. So even though all those values are really high, we need to do something in order for them to be able to pump things forward. So it's like one of the few exceptions, and I'm sure it's way more nuanced. I'm sure there's a lot more that kind of goes into it, but just kind of simplifying it down. And again, you don't need to um, know too deeply about it. Definitely not for class. Definitely not for the NCLEX. Maybe if you're on the floor, it might be nice, but all you really need to know is that this is like the exception to the rule. They need the preload, kind of like how that right-sided MI is the exception to giving nitroglycerin for someone with an MI having chest pain. So that is going to be the interesting thing with that. So this person's going to need O2, they're going to need fluids, and they're going to need vasopressors. So that's the interesting thing about this condition here. So let me see here. I'll post that there. And let me see if I can. Let me see if I can find more information about it. See if there's anything that can potentially clarify anything that's muddy. I think that's pretty much all they really went over, was just like they need the preload. Yeah, if you're interested, you could look it up, but you don't need to worry too hard about it. It's just one of those things that's just kind of this is the one exception to one of the exceptions to the rule. Any questions on cardiac tamponade? So I think again the focus is really going to be whether you were able to assess the Beck's triad, the understanding that even though this this condition has high CBP and high PAWP, that you still give the fluids because of the preload, and it has a lot of the same conditions because they end up this condition with the pericarditis is pretty closely, they kind of go together a little bit. Okay. So let's do the AAA, the AAA, the abdominal aortic aneurysm. And honestly, for the most part, a lot of the aortic aneurysms are pretty similar. Just depends on the positioning and the pain. You'll feel it in different places. It's that tearing pain. That's the key word that I saw on the U World when it came to the aortic aneurysm ruptures. So But general information, large area, and in this specific case is abdominal. So in the lower part of the aorta, so in the abdominal area, that's bigger than 3 centimeters. Your main causes are atherosclerosis, uncontrolled hypertension, and trauma. And let me see what else I got for you guys. The diagnostics, I'll just give that. Because I've kind of just been saying a lot of the same stuff over and over again. So the ultrasound is going to be the most common and accurate way to measure the aneurysm. But there's also the abdominal pelvic CT scan. Okay. So let's kind of break it down between symptomatic, make this more like manifestations, probably a little better. Manifestations, non-rupturing first. How is it going to be when it's not ruptured? Yeah, so the bruit, the swoosh, the pulse, yeah. So this person can have, can assess a thrill or bruit in abdomen. Possibly, yeah. Especially if they're thinner, yeah. Is the patient gonna be suffering from any symptoms, complaining of anything? If it's fully like like you know for sure it's non-rupturing. Are they gonna be complaining of anything? Yeah, so this is usually asymptomatic, but it's all about monitoring and making sure that they don't become symptomatic. What is like when it comes to the thrill and the bruit, somebody has like a little, let's say they have an an aortic aneurysm, abdominal aortic aneurysm. You see a little lump somewhere. You see the bruit and you see the thrill. What is something you don't want to do when you're assessing this person? Yeah, let's try not to palpate. Let's try not to rupture it. So that's going to be a key thing. So if you see an answer choice that says to do that, yeah. So it's kind of like your DBT where like they love putting in like answer choice for DBT is to massage it. It's never to massage it. It's kind of like that where like your Kaplan-Ural questions they love having this one here. And heat either, no heat either. Kind of also similar to your appendix. The appendicitis is let's not palpate. Let's not put a lot of pressure there. Let's not put heat there. Let's not make that thing rupture. Same idea. And now if it's rupturing, this is life-threatening. And we did talk a little bit about it when it came to the aortic dissection in the IABP. So, but this is gonna really kind of function the same way. You're gonna have sudden abdominal, lower back pain. They call it like a tearing pain. I see the tearing pain be used more in the Kaplan-U world. So just letting you guys know. Menat change. Menat change. Mental. Oh, okay. I was like, what is that? I'm having mental changes right now. Like just how long I've been. I was working on in the sim lab this morning too, so ugh. Poor capillary, yeah. So we're gonna see some ultra level of consciousness. We're gonna see some poor capillary refill to the aneurysm. Yeah, so we're gonna see probably maybe even no pulses. So we might see some BP drop and clamping down because shock, slower cap refill. We're gonna see changes in their perfusion. We're gonna see a lot of shock kind of things. You're having hemorrhagic shock. Basically like no pulses distal to aneurysm. Ooh, this is super life threatening. Yeah, exactly. Cool. So the Turner and Cullen sign Probably let's go with colons. Probably colon and Turner sign, like those. When it kind of also goes with abdominal distension. In this case, it's the bleeding. That's what that's referring to. Maybe assess the abdominal girth or whatever. They might be shortness of breath due to compensation. Due to all of this happening, they might also be dizzy, nauseous. Let's say nausea, vomiting, dizziness. All of this stuff that I think you can attribute to shock, lack of perfusion, and whatnot. All right. So just for knowledge sake here, let's just write it down and talk about it. Or I'll write it down and talk about it. So when it comes to the management, a lot of this is monitoring. So and it's based on how big it is. I'm sure it differs between doctor and doctor, but we'll go with if it's less than 5 centimeters, monitor every 6 months using the ultrasound, and probably educate the patient on signs and symptoms of when to go to the doctor. If it's 5 centimeters or more, or it's just growing quickly, then some things that could be done to fix it if maybe they're ruptured. Major open surgery, or the endovascular stent, which is something that you guys go over, but it's pretty basic, the endovascular stent grafting. So I didn't include it, and he didn't include it in the little thing either. It is a lot of information, but for the most part, it's like a pretty basic pre-op. So it's like informed consent, MPO, type and cross, no straining or bowel movements. Yeah, yeah, for sure. Yeah. So yeah, that's some good patient education there. Cool. And then of course, assessment. When you're thinking about perfusion, you're always thinking about kidneys. You're thinking about urine output because the urine output could be one of the first signs of shock. And then your kidneys, of course, love perfusion. They need to be perfused. And if they're not being perfused, they will complain. All right. Pretty much that. Coronary angiogram. Let's see. You can diagnose, treat cardiac conditions, show blockage, and we have a pre-op and a post-op, but it's pretty basic. But let's see. The pre-op is always pretty, like relatively, it's gonna be basic, like MPO, DC anticoagulants. Patients should not be on metformin, which we also know, because they're gonna be using contrast ID or contrast IB. We need baseline vital signs. We need EKG, chest X-ray, echocardiogram, which you guys have been saying every single time for like everything. So I know you guys have that ingrained in your brain cells. Answer for antibiotics, yeah, I think probably that one would be used. It's same thing as the probably same thing as the stent, if I imagine. Conscious sedation could be used, but let's just kind of go with these basics here. Post-op, what do you guys expect post-op? Again, very basic, really, for the most part. I would say the main thing is that this is done on if it is done on the femoral, that kind of changes some things. So, yeah. Checking distal pulses, okay. So we said positioning, we said keeping it flat. Distal pulses, no heavy lifting. Monitor your labs. I'm sure you guys want to monitor your vital signs and your EKG as well. And then, yeah, I would say keep your blood pressure, yeah, not too high. I would say not too high and not too low. Definitely not too high. It can place too much stress on the graft for sure. say bleeding. And then last things that I know if it came up, you guys would know would be because they used a contrast dye, you want to flush it out. And again, perfusion equals kidney stuff. So eyes and nose, urine output. So all this good stuff. Pretty basic. Pretty basic pre-op and post-op at this point. Yeah, metformin should be held, which is why we don't give metformin to type 2 diabetics in the hospital, typically. Just in case something needs to come up, we're just gonna put you on some insulin. All right. Any questions on this? It's pretty basic pre-op and post-op. And the main thing I think that is to keep in mind is this thing. If it's femoral, just keep in mind your rules for the femoral artery. If you have a question, they will specify they'll likely specify it was done in the femoral artery, or keep in mind if it doesn't say femoral artery, if it was done in the radial artery or something, just keep that in mind. Okay. So then there's the cabbage, which you don't need to know too much about. The main thing about it, I would say, is probably your education. And I have some other stuff here that might be good. So it's just the peri-op. So let's just go boom. So here, standard peri-op or pre-op here, it'd be the informed consent. You need to make sure the patient's stable enough. Type and cross. This person's should be in the ICU after the cabbage for monitoring. But we need to make sure that if they were to be bleeding, then we have the ability to give them a blood transfusion. Your education after a lot of your very typical post-op, a lot of your very typical post-op teaching, splint, IS, turn cough, deep breathe, early ambulation. Something to keep in mind with the cabbage is that there's going to be a harvest site, and it's typically the saphenous, right? I think it's saphenous. I don't know if you can hear Kaylin. She just woke up. Yeah, harvest site. So make sure to check your pulses on wherever the distal pulses on wherever site that is. So probably pedal pulse if it's on the saphenous. Yeah, so infection and all that stuff. Things that are expected after surgery, a sternotomy. So that's the little cut, in the sternum. So this one, you get to look kind of cool with your scar. Wow. They'll be on a chest tube. They might even be on ET, so endotracheal tube. Yeah, they'll be intubated. So VAP bundle could be intubated. Yeah, so your VAP bundle plays a role in it as well. And yeah, cool. I included it. Patient is so this is something that can happen is the patient's at risk of developing AFib. So post-cabbage AFib is a thing that can happen. We talked about it, I think, last week or the week before that. I can't remember. One of these weeks we talked about it. Pulmonary edema, ARDS, acute. Oh, I ended up putting in the refrigerator, so yeah. Acute respiratory distress syndrome, which you'll learn more about in I think it's next week, huh? Next week or the week after, I can't remember. But yeah, the manipulation of the chest cavity, the inflammation, surgical stress, all that can lead to dysrhythmias. And you'll learn more about that with your sepsis and your ARDS for the next time. So yeah, your body's compensating. It releases a lot of those catecholamines like your norepinephrine, epinephrine, dopamine, and like I mentioned, those things trigger your fight or flight more. It demands more out of the body. It can cause dysrhythmias. So sometimes your sepsis can lead to an MI, can lead to dysrhythmias and stuff. That's next week for you guys, but they're on. This is technically their 4th week, but we're going over week 3 because their test. Yeah, I think it makes sense. Because our BSN is week 3. It's week 3 of our BSN. So actually, kind of our weeks correlate with the weeks we're doing their outline. So that's I just yeah. But yeah. And then again, and any questions on the anything we talked about before, or any questions on the meds? With the meds, I was just kind of gonna quickly go over it because like, we don't really have too much time. But for the most part, hi Kevin. No questions on any meds. No questions on anything previous. Any clarification that's needed is fine. Speak now or forever hold your peace. Yeah, there's a lot of stuff. It's a lot of meds. Yeah. Yeah, so you've had experience in the ICU during your preceptorship. Any insight?
You see Levo a lot.
Oh, really?
It's like will be your main presser because I mean the biggest part with
Oh, you meant levofed. I was like
it's
levo.
not levothyroxine.
Yeah, I was like, what are you like? Oh, really? Oh.
So your levofed or levo will be your most commonly used presser if you're in the ICU because it solely affects blood pressure. The issue with that though is because it's such a strong presser, it'll clamp down everything. So what assessment do you need if you have someone who's on levo because of that? Vitals is on. Oh, you put the thing on me. Hello. I feel like this headset kind of reminds me of like the ones that you see with the news people have.
Oh, yeah. Like
Yeah. Yeah. I like that. Oh, your patient was on levo the other day. What did you assess? What did you see?
So yeah, he was on levofed when I got there. He had hemodialysis. And so his blood pressure really dropped. So they actually brought it up 2 micrograms. And then they brought it down. And then the nurse was trying after dialysis, like maybe an hour before I was leaving the floor, the nurse was trying to wean him off of it. So we brought it back down to 2, after dialysis, and his blood pressure was back up. And then she stopped it, and his blood pressure literally went from like 125 down systolic down to like 112 within like 3 or 4 minutes.
Oh, gotta love that. That
I would like
really...
ran to the nurse. I was like, so yeah, it really dropped. She's like, we're gonna wait another like 15, 20 minutes just to see how he does. It's like, okay.
Yeah, sometimes, I mean, that's it. When you said 120 to like 112, right? That change in
Yeah.
systolic. I
Yeah.
mean, sometimes you're going to get stuff like that, especially because we just wean them off of it, right? This is a really strong presser. So if you wean someone off of it and you take them off completely, sometimes it takes a bit for them to adjust, and at the end of the day, like you guys learned in your first week and what, I don't know, may or may not come up again this week, with your hemodynamics, making sure your map is within a good range, right? Because our systolic and diastolic, quote unquote, may look good, but our map could still be too far down, so we're not getting enough perfusion. So what guided the titrations of levofed for this patient?
Although they are just trying to get him off of it.
Gotcha. What assessments did they make to determine we need more, or we need less, or they need to go back on?
I think just that his blood pressure had been normalizing.
Cool beans. Pretty
Yeah.
much, yeah.
He was also on another presser that I gave him through his NG tube in the morning called I'd never heard of it. It was called midodrone. Midodrine, yeah.
Gotcha. I saw that a few times, typically for low blood pressure. Some people take that daily. My grandpa's one of them. Midodrine, yeah. Yeah, it's pretty common. It just depends on what floor you're on. That's good that you got to see that and experience that. Because titration is a large part of these meds, and why it's a good thing to have, if possible, to have A lines on these patients or very, very frequent NIBP. But with this being such a strong pressor and it just clamping down so hard, there's a risk that we could end up clamping too hard and cut perfusion to certain areas of the body. So you need to be doing your CMS when you're dealing with those, because you might end up with toes and fingers that are a bit discolored. Pedal pulses, yep. So your CMS in all extremities, yep. Some scary stuff. Let's see where we're at. I feel like y'all know this part. Cyanosis, yeah, discoloration. Is it cool? It's kind of like your 6Ps to an extent. Let's see. We know our preload enhancers. They just essentially more fluid. Robbins mentioned it too. Good. Yeah, Robbins is pretty good with his lectures. I like listening to them. I feel like a lot of times he's very specific on what he wants.
Also, I made my own mnemonic because I didn't know what he meant by park. I'm like, I don't get what that means, so I just like made my own. Instead of the 3Ps, it's like I did. That's right here. Dip,
Oh, yeah.
tap, preload, diurese, inotropic,
And pivot or move the blood somewhere.
I don't know. It made more sense to me, but whatever, do whatever works best for you.
True. And then remember, some conditions, like your right-sided heart failure, even though you have that high CVP, and technically that is a criteria to use your preload reducers, they have that pump failure. But if you take away more fluid from them, then you're gonna crash them out.
Similar to how we talked about earlier with the right-sided MI, where nitroglycerin's contraindicated. Similar concept.
Yeah. Cool. Let's see.
Which came up during sim today, which is why I
Oh.
It's like, oh yeah. Well, I knew that's like deep in there.
Deep in the brains. But yeah. Ooh. Yeah, I didn't mention this other part. Perfusion to the kidneys and other organs with their levo-fed, because we can have such strong clamping down. Monitoring your urinary output is a big one with this. Measuring and looking at the characteristics of your urine as well. So we know, amount, color, characteristics. Is there anything floating in it? Float. Is there anything in there that shouldn't be? Does it look funky? Have fun.
I'm a nerd, so like I included a bunch of like, oh, this is a alpha one. Don't worry about that. Just worry about
I never got that.
like worry about what it does. Increase heart rate, increase heart rate, increase blood pressure. That's all you need to know. I don't need to know that it tickles the alpha one, tickles the you're fine. You don't gotta worry about that. He does go over it, but you don't gotta worry. For the most part, also don't worry too much about like hard committing these dose depending things on when it comes to like your dopamine and whatnot. Yeah, it's not like something for you to hard memorize.
Yeah, because I am not somebody to understand the big mumbo jumbo. I'll just be like, heart rate, no change, blood pressure change, crazy. So, I mean, if you know that though, like you're set in stone.
Know about the anti-XA factor?
I don't know what you're even talking about. I don't know. I know what heparin does though. But yeah, so I like here that I'm not even sure if this was changed on our notes, our dopamine. There's been recent studies because it was hypothesized that you could administer a low dose for renal vasodilation. I almost said constriction, vasodilation. But there's been newer studies that have been disproving that. If for whatever reason this comes up on your test, go with whatever was on your notes, go with whatever Robbins might have said about it. So just a little random point. Let's see. But yeah, this one's a big one for your contractility. So what condition could this be really good for? I'm pretty sure you guys already talked about this. We'll take another sip of this Alani. Yeah, yeah, that cardiogenic shock where you need that squeeze because we have a big old pump failure. So it needs a bit more squeeze. I like to think about this as the squeezy one. The squeezy one. Let's see. Heart rate increase as well, but it's also a vasoconstrictor, which is quite ironic. A couple things to look out for there. So watching that tachycardia, because you could have heart rate increase, chest pain because of how hard we're making the heart work. We can use up a lot of oxygen there, so we might cause some cardiac ischemia. I forgot why this one happens. I always forget. It was something to do with something.
It's a dopamine is gonna affect your, so you see here it affects the beta 1 and alpha 1, so this is affecting the sympathetic your sympathetic nervous system, therefore it's causing fight or flight. When your fight or flight is happening, you end up having an increase in sugar because your body needs alertness. Same thing why your corticosteroids will increase your sugar because leads to the same idea.
Oh my god, I almost got that right. Yay. Let's see. Oh, adrenaline. We love that. So same kind of thing, tachycardia, blood sugar. Epinephrine's really good for contractility and heart rate. Not as much for a pressor though. Unless you're like squeezing it up there. I think the max was like 30 if I remember correctly. 30 mics per kilo per minute. So it's quite high up there. But these are good for people who need an increase in heart rate and still need that extra squeeze. But something sympathetic, whatever Diego said, causes that blood sugar increase as well. Let's see, dopamine is also another good one because it has strong contractility increase. So, or strong increase you know what I mean. Increases contractility. So that's another good one for cardiogenic shock. This one, honestly, I don't think I've even, yeah. What is it? Phenylephrine, strong vasoconstrictor. Ironically used for mild to moderate hypotension. I feel like its use is very minimal and it's definitely not first line.
Kind of like babies first.
Babies first norepinephrine. How funny. Let's see. Afterload reducers. So afterload reducers vasodilate to decrease the SVR. So those are anything that vasodilates. So we think the nitroprusside. This is a big one here. Byproduct is cyanide. Cyanide.
But the nice thing is at least the number for the toxic thiocyanate levels is the same as the digoxin, so that's nice.
That is very nice because my memory with numbers is not very good. So yeah, looking for that thiocyanate, the big word levels of 0.5 to 2. And remembering like, oh, it lines up with the digoxin. And it has like some kind of the same. I just look at the nausea, maybe some muscle weakness. It's like that could be digoxin too. But yeah, just because we are vasodilating pretty hard in some cases, and this one is used for hypertension, hypertensive crisis, we could drop them out too far. So, you know, that's our thing with any med. We can go too far in the opposite direction. So we can end up crashing them out. So just be prepared. Don't be that person where it's like, oh my God, this accident's going down and I have nothing in the room to help me. Be prepared. Keep that normal saline prep just in case. Just in case you need to just slam it right open. The contractility enhancers. We already talked about dobutamine and pump that D. We already talked about dobutamine and dopamine, and then here's our digoxin again to increase our contractility. Watch out for that decreased heart rate. Here's that same level again, 0.5 to 2. Knowing that hypokalemia and digoxin have an inverse reaction to each other. So hypokalemia can cause increased digoxin level. Always check your apical pulse before giving because this causes a decreased heart rate. And knowing your signs of toxicity. So the big one you'll usually see is some visual disturbance or a green-yellow halo.
If they're nice, they'll specifically put green yellow. A lot of times in the U world, they were just putting blurry vision.
Oh yeah. So it could be a little vague sometimes. This one I always got confused with midodrine. I don't know why.
Because they both start.
They both look the same to me. So it's one of those. What's the word? Like in the book, remember first semester they used to tell us
Oh,
like the
yeah.
look-alike drugs.
Well, I forget. Yeah, yeah, yeah.
Yeah, to me this is a look-alike drug in my head, and it probably is on paper too. Midodrine versus milrinone. In my head, they kind of look similar. So this would be a med that I would really triple check. Let's see, for low cardiac output during heart failure, so you have that contractility and increased heart rate. But because it vasodilates, you need to watch out for their blood pressure. Considerations can cause, oh god, VTAC fun. Hypotension, again, we crash them out too far. Monitoring potassium, magnesium long term.
We actually talked about this in the beginning. I think it was Josh, and I think a few, maybe Jude also mentioned about how kind of looking through the potassium because it affects the potassium level, so it can cause. That's probably why it causes the VTAC.
Oh, I just poked him in the eye with the microphone. My bad. That makes sense. I didn't think about that. Cool beans. Is that all we have for them?
Yeah.
Okay. Do y'all have any questions, comments, concerns, family problems?